Hi everyone, my name is Alaa. I am interventional radiology consultant based on Countess of Chester Hospital in the UK. I heard that the vast majority of you are also interventional radiology. Is that true? So most of these beautiful things which you show, I didn't understand most of what you said, but in the UK is done by the vascular surgeons. It's really difficult for us to offer varicose vein treatment. I don't know how you did it, but you are doing a very good job. So, with regard to the DVT, mainly the problem, it's frequent abnormality, and almost half of the patients develop post-thrombotic syndrome. So, people started to do catheter-directed thrombolysis and offer also mechanical thrombectomy and think of to reduce the frequency of post-thrombotic syndrome. And the ATTRACT trial was done, and everyone was thinking that it will confirm what we have been doing, but unfortunately, Yep. Yeah, okay. But unfortunately, the ATTRACT trial did not confirm that catheter-directed thrombolysis reduce the rate of post-thrombotic syndrome in patients after DVT treatment. So for the trial was randomized two groups of patients. One group went for anticoagulation, and the other group was offered catheter-directed thrombolysis. Patients with only DVT confined to the below-knee segment were excluded from the study. And as you can see, that the study showed that 48% with patients developed post-thrombotic syndrome after 2 years, which was disappointing. 24% developed moderate to severe post-thrombotic syndrome. And the overall, it did not show any huge significant difference between the two groups of patients. Also, with regard to the patient comfort, there wasn't a huge difference, small difference with regard to the swelling and pain in the acute phase. And to make things more interesting, also patients with catheter-directed thrombolysis developed more bleeding rate, which was a bad thing for the treatment. The only difference was, the only positive thing is that moderate to severe post-thrombotic syndrome in patients who had catheter-directed thrombolysis was around 24%. 18% were in the anticoagulation group was 24%. Also, with regard to the improvement to the life quality to the patients with DVT, there wasn't a huge difference between the two groups. So the conclusion is that catheter-directed thrombolysis for patients with DVT did not show a significant difference with anticoagulation group with increased risk of bleeding. But people who were working on this study were thinking that the selection of the patient wasn't the best one because a certain group between these patients were, for example, with DVT below the common femoral vein, and these patients should not be included in the study. And if the study was only for iliofemoral DVT, the outcomes would have been better. And now I heard that there is another study going between the UK, Holland, Germany, I think, thinking that the next outcomes will be better. With regard to the DVT in the UK, it's treated based on the NICE guidelines, which is something like a Bible in medicine there, and you have to follow NICE guidelines, and if you decide to do anything out of the guidelines, you need to justify what you are doing. Treatment of DVT almost in all Europe is the same. So if you suspect DVT, you start treatment and you go in the diagnostic process. Once you confirm the DVT with images, then you continue a treatment with anticoagulation. If the patient is contraindicated for anticoagulation, then you offer mechanical intervention. And mechanical here, I mean IVC filter. Also, because pulmonary embolism is very much connected to the DVT, and it is a sequence in most of the time to the DVT. So the paper, the NICE guidelines, took in consideration also the treatment of pulmonary embolism, which is almost similar. Once you see pulmonary embolism or suspect pulmonary embolism, you start anticoagulation. You go for images. Once you confirm it, you continue anticoagulation. If anticoagulation is contraindicated, you go for mechanical intervention. And here is the point with regard to patients who are hemodynamically unstable, then you can offer thrombolysis therapy. Thrombolytic therapy in DVT is also allowed, but in a certain criteria. So it needs to be acute 2 weeks from the beginning of the syndromes. The patient should be in good functional status. The life expectancy is more than 1 year, and low risk of bleeding. For thrombolytic therapy in PE is you only offer thrombolytic therapy for PE patients if they are hemodynamically unstable. There has been a huge discussion and disagreement between clinicians and the paper with regard to patients who had right ventricular dysfunction but hemodynamically stable. And you can see on the CT scan that they have massive pulmonary embolism, but they are stable, so we are not allowed to offer thrombolytic therapy. With regard to IVC filter, so as I said, if the patient is contraindicated for anticoagulation, you offer IVC filter. Yeah. A lot of things which is, I think, not important. With regard to percutaneous mechanical thrombectomy for acute vein thrombosis, which we offer in our hospital, unfortunately, after the ATTRACT trial and I think Canavan before, there has been a little bit retrieve back with regard to offering this procedure, but it's still there for patients who are symptomatic and who have massive iliofemoral DVT. We don't offer it for patients with femoropopliteal. And because it's not very much approved, there is a lot of things as a clinician you need to do with regard to allow yourself to provide the procedure. So the medical governance and the special consent form, and you have to explain to the patient everything, and you have to have also everything in written, in leaflet, and give it to the patient before the procedure, and keep a certain time between the procedure and the consent for the patient to decide whether he wants to go ahead with the procedure or not. And also we need to provide every case we do for the National Registry because to see whether we are doing well or not with our treatment. With regard to the procedure itself, I think everyone who's doing intervention and arterial work, the acute vein thrombosis treatment will be a basic one. So usually the puncture would be whether popliteal or you get a neck access. Usually if the femoral vein is clean and you have confined iliac, then you go for femoral vein puncture. And depending on, in our hospital, because we have only one IR room, so we can't offer every patient mechanical thrombectomy immediately. If the patient is lucky and he comes in a day where you have more time to go for suction, then we start with suction, we debulk the thrombus, and then we continue with the thrombolysis if needed. And most of the time we do thrombolysis. Centers who are specialized in treating venous disease and they have more time for this, usually the procedure can be done in one day. So you can do thrombolysis and suction and stenting if needed in the same day. But also that depends on the center. In Chester, for financial reasons or to convince our financial people that what we are doing is helpful for the hospital, so we had to do a study to justify having a mechanical thrombectomy in our hospital. So the aim of this study was retrospective. We just checked the cases we have done retrospectively and we did comparison between the two groups of patients who had mechanical thrombectomy and the others one who had only mechanical thrombectomy with thrombolysis. Now, these who had thrombolysis alone and others with thrombolysis and mechanical thrombectomy. And we found that patients who had mechanical thrombectomy, that reduced the time of thrombolysis. And in terms of ICU beds, because you know ICU bed, I think it costs in the UK around £3,000 a day. So if we reduce even 1 day the stay in ICU, that is a good financial thing. I won't get in the details of these patients. But yeah, the conclusion that with the use of mechanical thrombectomy and we use penumbra suction, we found that we can finish early with catheter-directed thrombolysis. I just wanted to share with you just in real time how cases look like in our hospital. Yep. Let's go over case 4. I didn't have time to prepare this properly. So the first patient was 41 years old, female, with extensive iliofemoral DVT for urgent thrombolysis. This is exactly how the referral look like. So usually the patient is seen by whether the vascular team or the acute medicine team, and they, after doing the images and confirming the diagnosis, they contact with us with regard if we will be able to offer the patient the procedure. Yeah, thank God. With these patients, I think it's really very important always to check the scan yourself. So you can see the thrombus in the left side going down to the common femoral and to the femoral. And as I said, most of these cases is it will be if the femoral vein is diseased, thrombosed, you go for popliteal puncture. I personally prefer to access the popliteal vein through the gastrocnemius vein. And when you puncture the gastrocnemius, it has a certain direction to the femoral vein. And then if you go for stenting, for example, and you use 10 French sheath or more, the compression in the last day is much more easier. And you can see how massive the thrombosis with this lady was. Of course, the first day, if you go for thrombolysis, it's around 10 minutes procedure. You just do the puncture, cross the lesion, put the Fontaine catheter, and start the thrombolysis. With regard to medication during the thrombolysis, once you get the puncture standard, you give 5,000 heparin or less if the patient is smaller, or bigger, more if the patient is bigger. We give in bolus 10 milligram Actilese in the first, after crossing the lesion. And we start the thrombolysis with 1 milligram per hour for 24 hours. And we give 1 milligram through the catheter and 0.25 milligram through the sheath. If the patient is large diameter, or if he is also younger, sometimes we might give more Actilese to finish early. But with older people, we tend to be a little bit more cautious, so not to exceed 1 milligram per hour. And that lady had underlying May Turner, so we had to put a stent in after the procedure. This is the last day. We use sinus oblique stents because they have this oblique shape, so you can put it at the bifurcation. I'm not sure whether this make a huge difference, but yeah. I'll show you just one more case. This is another lady, 56 years old. Yeah, with DVT. With regard to checking the scan by yourself, because sometimes other reporters might miss a small lymphadenopathy in the small pelvis, or small things underlying, and we had a case where there was missed cancer underlying, and unfortunately we noticed this after 2 years when it was disseminated. And it was present on the initial scan, but unfortunately was missed. And here you can see how much the left iliac, common iliac vein is distended and thrombosed, and the thrombosis is going all the way down to the below knee, below common femoral segment. So first day she had the lesion crossed, and they started thrombolysis. And that is the second day, where when we started we noticed a little bit residual thrombus, so we did some mechanical thrombectomy. Continued for 1 day, and that is the last day. Thank you.
Thank you very much.